Good morning, everybody. My thanks to Heinrich, Sarah, Catherine, and OcuMel for inviting me over today. Just made it. The train was 20 minutes late, but we got here. Yep. Nope, not at all. Find my slides. Okay, so that's me. We're based in London at St Bartholomew's Hospital and Moorfields Eye Hospital. And as Heinrich says, we're one of 4 centres in the UK. I adapted this slide on the way in because I thought it depends on the news. It might be 3. And then I checked Sky News on the phone, and apparently it's not. So we're back to 4 again. As a service in London, we see really adults only, although we have a retinoblastoma service at Royal London Hospital, which is part of our trust, which looks after paediatric tumours and paediatrics generally. We really look after lumps, bumps, masses on the surface of the eye and on the interior of the eye. We don't really do lids and orbits. There are people for that, particularly at Moorfields for us. The last year, we're getting around 1,100, 1,200 referrals, which is really a lot for a service of our size. And we are part of a team. It may be me standing here, but I'm just one of a lot of people, from the doctors, the administrators, the CNSs, our medical oncologists, radiation physics, pathologists, and a lot of staff. So it's really a team effort. I always say to people, what's the goal of the treatment? Unlike the rest of ophthalmology, it isn't the same. My first role is to try and save your life. This is life-threatening disorders. The second is to save your eye. And third is your sight. And the priority is actually in that order. There are a lot of possibilities in the eye. I mean, we talk about melanomas a lot, but it's one of a textbook of potential lumps and bumps. Different types of benign and malignant tumours, hemorrhagic things, like types of macular degeneration, and inflammatory diseases. We don't always jump to conclusions. So a little overview of what sort of things we would normally see. A very common are moles, or choroidal nevi. We think it affects 5 to 10% of the adult population. They're generally pretty benign looking things. They're small, fairly flat, different colours, usually pigmented. And if you have no risk factors, the actual chance for a little small nevus turning into a tumour is actually really low. It's just under 1 in 9,000 chance in a year. And you always hear about this, the TFSOM, the risk factors, things like thickness. Are these things leaking inside the eye? Do you have the right kind of symptoms? Do you have orange colour? Where are they in the eyeball? And there are benign features, aging changes, that tend to make you think this is not an active disease. And we count how many of these things you have, because there is a risk. And the more of those factors you accumulate, the greater is the chance that you've got a tumour. Going back sort of 20 years, London was run by John Hungerford. And John used to say, as far as he's concerned, there's only 3 things: thickness, fluid, and orange. If you've got one of those, it's suspicious. If you've got 2 of them, it's very suspicious. And if you have all 3, you treat it. Pretty straightforward. And these are the kind of moles you find in eyes. Little circumscribed ones, funny looking grey ones with old tails below them. They come in shapes and sizes. And what we generally do, if you get sent to, I'm sure, all the services, we take a photograph, we do an ultrasound scan, particularly if you've got any thickness. If it's very much textbook benign thing, we'd send you back to your local hospital or a good optician. I'll give you a photograph and say, go every year to your optician, take the photo and show them. And if it's different, let us know. If it does change, then we'd say that is the signs of a small melanoma developing, and we think about treating it. Radiotherapy, laser, various bits. And the main group, and probably you're most interested in, are melanomas. They are still rare. You sit in the clinic with 60, 80 patients waiting, all with tumours of some description. You think everyone's got one. But I'm told you're about 20 times more likely to get one in your skin than you'd ever get one in your eyeball. And the incidence is inversely proportional to the colour of your skin. So someone like me, my risk is a bit lower. The more fairer, paler, freckly, sort of Anglo-Saxon, theoretically and statistically, the more likely you might get one. But we only see about 7 cases per million of the population. The numbers are small. If you look at figures over time and age, well, as you'd expect, it's predominantly a condition of later years in life, 50s, 60s, 70s upwards. Though we have had a few teenagers and I think a 2-year-old with a melanoma, which is I think our current record. Incidence by year, if you follow it over decades, they haven't really changed a great deal. It's just a slight upward trend really with just an aging population. Common places you hear about, most occur in the back of your eye, about 15% in the ciliary body, a little bit nearer the front, and about 5% or less in the iris. It's usually always in one eye. It's very rare to have both eyes affected. And there are a few risk factors that increases your chance of getting one. And one of them is what we call ocular dermal melanocytosis. Nice long name. It's basically people who've got a lot of pigment in one eye. So you find there's pigment patches on the white of your eye. The iris is a different colour from one eye to the other. When we look inside, you find the interior structures are darker from one eye to the other. And you've got about a 1 in 400 lifetime risk. So we say all patients with this condition should be monitored by the service, sort of usually annually, regardless. People present in lots of different ways. Most common things are flashing lights, visual symptoms, change in the visual field. But about a third are asymptomatic. They go to the opticians for a routine test and they find something, and it finds their way to an oncology service. And as a general rule, I say to people, the ones that are at the back of your eyes tend to be found earlier because either they're giving you symptoms or someone looked in and saw them. The trouble is they're worse for vision because they've either already damaged your eyesight, just the fact they're there, and our treatment's not going to help. But you find them when they're smaller. It's better for you generally. Going back to how one of the earlier pictures of a mole, that was a mole on that side, and it certainly grew. It's got larger, thicker, and a nodule growing out of the middle of it. It certainly happens. Other types of examples, top left is the sort of pigmented patch with a lump in it. Large white ones, that's a classic ultrasound with a little mushroom-shaped nodule growing in the back. I've never actually seen one of these because I never really do angiograms, but textbook says if you do an angiogram, which is a sort of dye test of the eye, you can pick up a circulation within the lump itself. Another example, big mass and a big detached retina, which is one of the common features of it. That often gives you more symptoms than the actual lump itself. And then we thought, a few pictures of other things in eyes. All in the back of our mind, are you sure? You can have very large moles. Look frightening, you measure them, they look really big. Don't do very much. This is a metastatic deposit from a tumour elsewhere in the body. It happens to have shown up in the eye for the first time. Bottom left is a hemangioma. There's a collection of abnormal blood vessels. They're often very red, hard to pick up. The classic is they send you a photograph and say, please, you see this patient, it's got this. And you look at the photo and there's nothing on it. And you can pretty much say, I bet you it's a hemangioma because it's the same colour as the background, disappears in the photograph. The last one is a mole called a chirpy, a benign mole that's quite characteristic, very sharp edges, very dark in colour, and gradually gets paler and paler as the decades go by. The ciliary body ones are just in a location near the front of the eye, often hidden behind the iris, and sometimes you can see they grow forwards and peek out through into the front compartment. And irises are the least likely place and the best place to have a tumour if you're ever going to have one. They're usually very slow growing with a low potential for spread, tend to cause changes in the eye itself. It's great. I found a picture of one, and of course it's at the top, and it says commonly in the inferior, in the lower bit. Heinrich, Sarah will tell you a lot more about the genetics of it. It's really pioneered here. I always say in London we offer it to everybody. I think we're a bit different in our perceptions of the test and what it means for the patient. Personally, in London, we find at least half, if not more, will actually decline the test. And it's very variable, and I think it's how we present it and what the people and the patients want to do. Heinrich is quite right. You go back, say, a couple of generations before John Hungerford was a chap called Mike Bedford. And Mike's clinic used to run what now takes us 2.5 sessions, morning to evening. It was done by morning. Because he used to say, very old school, but would say, that's what you've got in your eye, that's the treatment you need, thank you very much. I'll let you know the date. Now, as the years go by, we're much more proactive, and we talk with the patients, and we spend half the day with them discussing the pros and cons of all the things. And there is a degree of information overload for the poor patient. There's a lot of information to take in. Some of them haven't been told anything. We're the last point to call who often have to give the bad news. And it's hard to expect them to really understand the pluses and minuses. I read a book by Henry Marsh, who's a neurosurgeon, retired, about his sort of anecdotal evidence of his practice. And he says in it that there is no such thing as informed consent. He said, of all the years doing neurosurgery, no one has ever read the consent form before they signed it. And I'm sure their consent forms are a lot bigger than ours are. But there is this question of how much information does the patient understand, especially in that first consultation. So we give them booklets to take home, and then we would say, well, we'll discuss it at an MDT meeting, and then we'll call you back again and give you a chance to think about it, mull it through, talk to your family, talk to your friends and doctors, and then make a final decision in a few days' time. So going back to some of the treatments, there's a lot of things that are now on offer. Probably 100 years ago, all they did was take your eye out, and that was it. But we do a whole host of things now, from observation to quite major surgery. So I thought we'd just look at a few of them, really. It's sort of against your thinking, why do you observe tumours? They're growing, aren't they? The iris ones particularly are really slow. They can take months, if not years, to grow. They may take a long time to change. You might think about patients who are really elderly. They've got a lot of other medical issues. People with only one eye. Are you going to treat something in an eye that you may just blind them? And I've got one at the moment who's a real heart sink patient, as we say, where the treatment is likely to be more damaging than the risk of the tumour. She's a patient who came to clinic in a wheelchair strapped to a tank of oxygen. Her chest function is so poor, the anaesthetist said, you are not giving her an anaesthetic, full stop. Not of any sort. There's a high chance she will not wake up afterwards. And what am I supposed to do about her eye? And I've got absolutely no, she can't lie down for more than 5 minutes. Her breathing gets affected, which pretty much stops every kind of surgery, radiotherapy I can think of at the moment. And this is going to be one of these cases we need a long chat with her and our CNSs, that maybe doing nothing is not such a bad option, considering her general health. You get that, she's coming next week. Laser treatment you hear about on the web and things like that, it's really not done. The old diode laser, it tends to give you quite a big scar. So theoretically you can do it if you're not going to zap your central vision. And we use it more as a second line treatment. We've had something else done, there's a little edge that seems to be growing, we might laser that. But it has its risks. The mainstay you hear about are plaques. We always used to say, and I still hope it's true, that Barts was the place that did the first plaque in the late 1920s. But at the Uretna meeting last week, we heard that there might be a German, as it turns out, who may have done a plaque about 10 years before us. So we may have to change that once we look up and find out if it's true or not. But it's our first choice for patients. It's a relatively straightforward procedure. It's a good success rate. It is radiation treatment, and you put it on the eye, and it's dependent on a lot of factors as to how long it's there, but it's normally on the eye for a few days. It takes a few months to see the effect. It's not going to happen overnight. That's the little plaque, the little disc. It's got the radioactive source embedded in it, inside a silver covering. They come in different shapes and sizes, stolen off the company's website. And that's how we basically do it. You locate the tumour by different techniques. I think it's Mr. Hungerford on these ones. Put the little disc on the eye. And that's the sort of classic way you can shine a light into the eyeball and make the tumour glow. You can mark out the tumour with a little bit of dye and put the plaque on. And they do work. You know, sometimes quite big things shrink and disappear. There's a sort of selection of pictures of all patients who were plaqued, lots of scarring, a lot of fibrosis. The other big one is proton beam, which is not that far from here really, a way of giving charged particles like external radiotherapy to the eye. In London, we really do it for either big tumours that we can't plaque, and maybe patients who don't want to have their eye removed, which is fair enough, quite understandable, and for tumours that are right up and around the optic nerve, because that's a solid structure behind your eyeball, and the little disc doesn't always fit very well. But it does have its own complication rate. So people go up to Clatterbridge, they have their planning organised, the mask, the calculations. We put the little clips on the eye before the surgery, before the treatment, so they can use that for marking, give them lots of measurements. They do all the calculations, and then you go and get zapped over a course of a week. It does work pretty well. Got a high chance of success of treatment in the eye, but we have found in practice that a fair percentage will have secondary complications. It's quite powerful stuff. And if you have a big tumour with a big detached retina, it's about 30–40% chance actually you might end up losing the eye because of the complications it caused, and about 10% for smaller things. So it's not 100% safe. And lastly, you take the eye out. It's really tumours that we just can't save. They're too large to treat any other way. We put a little implant back into the orbit to fill up the space, attach your muscles to it so you have some movement. And then patients generally get a temporary prosthesis done within about a 4–6 week period, and usually a custom-made one by the artificial eye service. And we do orbital radiotherapy if it's necessary. There are specific things we look at after the surgery when the pathology reports in. We might say, look, you need a bit of extra treatment to reduce the risk of recurrence. That's the little implant on the left we put in, and that's the prosthesis you end up with. They are really very good at doing them, incredible. And in London, we do preoperative staging of either chest X-ray, ultrasound, maybe a PET-CT, just to look for any evidence of spread before you start the treatment, or the evidence of a tumour elsewhere. I put this thing out called VOMIT, this thing called a victim of medical imaging technology. These are poor people who go to have one test, who find something they think. Then they say, have another one, which finds something possibly again. And they have a third one and a fourth one. And at the end of it, they say, nope, didn't find anything at all red herrings. We've had one lady who's particularly anxious, and every time you send her for a test, she worries about it, and you get a report that says, I'm 99% sure there's nothing, but actually there was this little spot. We want some more tests, and some more tests. It freaked out the poor dear. And lastly, I thought just a few pictures. We always talk about back of the eyes, choroidal melanomas, it's very common, but actually we do front of eyes too. It's the kind of things we might see. Benign stuff, papillomas, little sort of pinky front of tissues that turn up, these kind of things. Little sort of, we say they sort of look like almost a bunch of fine grapes. You get them in children, you get them in adults. They're benign in themselves, and there's different ways of treating them. There's a group called OSSN, Squamous Neoplasia, and it ranges from nothing, normal tissue, to what we call CIN, which is a sort of halfway house. Tissue's not tumour, but not normal either, and frank squamous carcinoma. It's a scale of a disease. It's related to local immune deficiency. So people who've lived a long time and worked in hot climates and sunshine, things like HIV, immunodeficiency, people on sort of treatment for suppose, liver and lung transplant patients on long-term agents. And you find them various shapes and sizes. This was CIN, so this sort of lumpy, pale mass on the eye, which was then just simply cut out. Another little patch. And frank tumour, big, sort of solid, pale, pinky masses of different descriptions. You cut them out, and there's a technique of how to do it. I won't go into that. And then you may give radiotherapy. We give a thing called a strontium applicator, which is, it's like a plaque, but it's a small thing, about 12 millimeters, on a long handle, so it doesn't irradiate me at the same time. We've got a little one and a big one. These things last for decades, and they're very hard to replace because the company who make them really don't want to spend a lot of money manufacturing them when they're only going to sell 3. So we've got to make do for now, unless we can get a bulk order together. But we can place it on the top of the eye. It treats the layers below it, and it's done over 5 days. And our little one is about 5 minutes. So the patient comes for 5 minutes, 5 days. The bigger one, which is a bit of a headache to get in and out, is about 12 minutes, I think, at the moment. Someone like myself, Asians, Afro-Caribbean people, we get racial melanosis. My daughter has a patch, and this is completely benign. People come to say, oh, please will you cut this out? I don't like this, but we're trying to avoid surgery. Last couple of things, primary acquired melanosis you hear about. This is the equivalent of that sort of squamous, scale of tissue. This is the same with pigmented tissue. So these are people who get this really in one eye. Patches of brown on the lining of the eye. What's important is to get a little biopsy of it and find out what it is and how atypical it is. How atypical are the cells? Because the more abnormal they are, the greater is the chance that you will have a melanoma, and you will keep getting melanomas, and you need lifelong surveillance. Really, if you've got no atypical cells, your risk is almost 0. It's questionable, really, do you need to be screened, certainly by a service. Because otherwise, you get a melanoma. And these are usually dark, lumpy masses that grow on the eye. And often, classic sign of the feeder vessels, big, juicy vessels feeding them. These are the kind of things, so big, dark mass, dilated vessels growing into it. And it can be enormous. We have a box in the clinic, which is sort of covered and locked full of horrendous photographs that were taken over the years. Some incredible people who've walked in the door with the most amazing disease. This is also, like the one in the eye, potentially fatal, not to be taken lightly. You can get spread through the lymph glands and out into the body. We do what's called sentinel lymph node biopsies, if the tumours of a certain size or above. We actually take biopsy of your gland with the help of our plastic surgeons to see if there's any evidence of sort of tumour cells early on. And they do, they come back. And you can die of it, so it's very important to look after these. There's lots of different ways of treating it, primarily surgery to cut the thing out. And then you may have adjuvant treatments like radiotherapy and mitomycin drops. And that's why I always finish. I think with all these pictures and slides in the clinic, we always think, back of your mind, is it possible I got this all wrong? And, thank you.
Thank you, Amit, for this excellent overview. Sure there are questions.
Anyone would like to ask a question? Can I give you the mic?
Catherine's doing the walk down there.
I had a question about one of the titles. It says, chromosomal imbalance is a bad prognostic factor. Could you just explain that statement?
Heinrich really is more the expert, I think, here, but in essence, if you take a sample out the tumour, we look for specific DNA abnormalities. And if you've got them, the calculation is that the risk of you getting metastatic spread is far greater than if you didn't have them. If you don't have them, it's not 0 risk. The question is always, we always have is, I say to the patients, do you understand what that means? I've got people who are, like we say, it's modern medicine. Patients who are very keen, want to know every detail, what the ramifications are, and that's fine. I've had a couple of patients, a young lady in particular comes to mind, who wanted to know what the result was, had the biopsy done, part of the treatment, and got the result and said, oh, okay, thank you very much. Came for a follow-up appointment with her mother in tears. And her mum said, ever since you told her, well, I didn't, but ever since she was told, she's been completely depressed. Life is over, I've got 2 young kids, they're going to be orphans shortly, I'm very upset. She said, tell her it was not true what you said. He said, well, I can't do that. But I always think to patients, you've got to understand, hopefully before you make that decision, that what does it mean? We're still, from our point of view, we're still going to screen you afterwards. We're going to follow the same. What we don't have yet is a way of making a difference for you. And that may well come with future trials and medications, more than we ever had. But there isn't a magic treatment, an eye drop, a tablet I can give you to make a difference. So I'm always keen that you understand why you're doing the test and what it really means for you. So I say to the patients, if you're of a certain age, when I was little, there was Mike and Bernie Winters, Morecambe and Wise pair on TV. And Bernie Winters had some sort of abdominal cancer. And he was on TV, and all I remember of him was he was being interviewed, and someone said to him, so what have the doctors told you about your tumour and your surgery? And he said, well, I've been told it's 100% either way. What does that mean? Well, if I survive, I'll be 100% alive. And if I don't, I'll be 100% dead. I think, actually, in some ways, that is the real truth. I say to the patients, these numbers, we will tell you this number, that number, 8%, 10%. In reality, for you, as an individual, Bernie Winters is right. It either is going to happen or it's not going to happen. So try not to get too fixated just on that number. And try and live your life and not worry about that risk. Yep. I suspect we have, and we've increasingly done so. It's not that we don't do it. I think we're not maybe as strong advocates for it. Maybe say Liverpool would be. We haven't done as many, so we always talk to the patients about it. But we find at least half will say no, thank you. Don't we? Yeah, I think it's got better. We are doing more and more of them. And I think for me, certainly, it's now standard. I have a little stamp of things on my notes that says we've talked about A, B, C, D, E, F, G. And that's certainly on the stamp when I go through every one now.
Amit, could you repeat any questions? Because the
Yeah.
microphones are working. So back there.
I thought you were asking to marry you or something.
I didn't get a biopsy because they said it was too dangerous and cause spread. Is that true, or what's the danger of that?
What are the risks of the biopsy? I mean, I don't want to preempt Sarah in a way, you see. Yeah. I mean, we were at Uretina last week, and I had a little presentation there. The chap who stood up before me said half the stuff I was going to say on my slides. I wish I got in front of him. But yeah, I might, if I may, just leave that to Sarah a little bit.
Regarding, are you talking about the surgical complications? I'm Doug Errington from Plaque. I'm sure you all know we've been treating patients with Proton now for 25 years. June this year, we treated 2,700. Just to go to this point about complications, as you might recall when John Hunt and I first started treating patients in 1989, the rather perverse thing about funding was we were only funded to treat large tumours because it was thought that the plaques would be fine for all other tumours. And I think for that reason, the initial results give a rather distorted view of the complication rate. And I absolutely agree, large tumours of retinal detachment we prefer not to treat with protons. On the other hand, patient choice is important. And a lot
No.
to save their eye. So I think that complication originally got a little bit overestimated because those are the patients we first treated.
We are going back, in fact, a study through all of our plaque patients. I know we were saying about getting some more numbers and details. I think saying they go to Clatterbridge and then they get sent back to their referring centre. You don't always find out what happens.
And that's the other thing we're trying to do now, as you know, from
Yeah.
medical and your work, we must try and get all the data from all the centres together. And the only major publication is from Berkeley's data that were published some years ago.
Yeah. We're collecting it at the moment.
So it probably is quite valid figures, but if we all put the data together, we'll sort these things out.
Thank you.